Hi Raju, how are you today?
Good, Michael. Great to see you from last Friday. And what do we have today?
Nice to see you, Raju. Oh, this week my consultation was full of the same problem. What I encounter since many months and years is a problem of vomiting in patient under methotrexate. Do you have the same problem?
Oh, yes, this is a big issue, and for me, it comes with even bigger consequences because after methotrexate, I have very little to fall back upon, and going to biologicals is a very major financial decision.
And how do you monitor your patient under methotrexate in your practice? And what are the side effects that you see in these patients?
Truly, Michael, methotrexate is really revolutionized care in pediatric rheumatology for the last 25 or 30 years. I typically start methotrexate in a dose between 10 and 15 milligram per square meter subcutaneously. I am not a big fan of starting it orally for bioavailability reasons. And once weekly, I'm very careful to say once weekly because I've had an occasional disaster with patients taking the medication daily and coming back with side effects. And obviously, with folic acid given daily. Now, in these very, very low doses, methotrexate is not really cytotoxic and it's known to act in a as yet undefined method by inhibiting purine pyrimidine synthesis. What I do is I tell them initially to do blood counts and liver function tests, maybe 6 to 8 weekly, but later on I uh, reduce the frequency to about once a quarter. To be very, very candid, I hardly ever see any adverse effects. Uh, an occasional hair fall, an occasional complaint of a mouth ulcer or cytopenias. The funny thing is that when I use methotrexate in lupus and when I see these adverse effects, these could also be the effects of lupus itself. So, this is a little practice point we need to keep. And very occasionally, I may see abnormal liver function tests in the form of raised uh, liver enzymes.
Yes, thank you for this explanation, Raju. And I think we are here doing very similarly. Uh, just a few differences. For example, I started the same dose, but usually I use it as a tablet because I know that the acceptance for subcutaneous injection is rather low, and it's sometimes difficult to convince parents and patients to go directly to injection. And we do also lab tests, maybe a little bit more in the beginning, and then with the time every 3 months. And I agree with you that it's very seldom to have increase of the liver test, but I think it's very important to do it correctly and regularly. I think it's less than 5%, I would say, that have liver enzymes increase, as we can see that in the literature also. And usually, when the patient are taking it for months or years, it's very seldom to find it, except if there are some problems with alcohol, and this is an issue in teenager, where sometimes you could have some problems with alcohol and methotrexate.
True, the alcohol could be a second hit, and maybe therefore the issue in adults would be different. But I think there are studies in children where they have performed liver biopsies after a long extended usage of methotrexate and found that the problem has not been significant as far as hepatotoxicity is concerned. But just asking you a question, Michael, this is all as far as toxicity. Do you encounter vomiting as a problem issue?
This is a problem what we really often encounter. Usually after a few weeks or a few months of treatment, this is a complaint from the parents or from the patients. And so it's very frequent. And so it lasts 1 or 2 days, often starting already before that the patient has taken his medication or before the injection. Sometimes when they see a yellow color, because a methotrexate is yellow, this will already induce nausea and vomiting. And this is important to say to the parents, because sometimes the parents they think that their child is just complaining just because the child does not want to have the treatment. And they don't believe that vomiting or nausea can start before they take the pill. And we have to explain it to the parents that the children have really nausea and that vomiting is not something psychological, but a real effect of the drug. And the problem is that you have low effect of the change to subcutaneously, because previously we thought, okay, if it's orally, then we switch to injection, but this is not very successful. And also they did not find really efficacious treatment for this, except that when we reduce the dose of methotrexate, sometimes it will decrease or abolish this side effect.
Michael, when you're talking about this methotrexate and vomiting, recently I came across a very interesting article from some authors in Holland, and they have looked at this problem in a slightly different and unique way in a small review that they have written. What they write is that you must differentiate methotrexate intolerance from methotrexate toxicity. So, if you have toxicity, that is your vomiting that occurs due to abnormal liver function tests or irritation of the stomach, gastritis. But intolerance, they subdivide into two parts: associative, meaning even if they are reminded of the drug may be 2 days away, but reminding of them of the drug, or anticipatory, even just before administering the drug, they start vomiting. And peculiarly, there are reports as high starting from 25% to as high as 50%. And these authors, in their article, even talk about something called a MISS score, as in MISS. Are you aware of this, Michael?
Yes, this is a score that was proposed, I think, by a Dutch team, because our colleague from Holland was studying a lot this problem with methotrexate. And this is a severity score where you have 12 items. And if you have six of them, you can really speak about adherence. Personally, I don't use it because usually it's very obvious when a patient is coming with these symptoms. If it's anticipatory and if it's recurrent, then for me it's enough to speak about intolerance. And then I can ask to the insurance to switch to a biological demand.
Now, indeed, this is comparatively easy for you to do. For me, to switch to a biological demand is a very big decision. So I have to work around this. But before we come to possible solutions, let me just tell you that this same author, they speculate on the various possible mechanisms as to why intolerance occurs. And in a way, what you said earlier about using oral instead of subcutaneous, because they say that if the child is reminded about the trauma of injections, it's something like a conditioned Pavlovian response. There has also been some look at mutations to susceptibility in the folate pathways, or in fact, even protective genes in the folate pathways. But a very interesting postulate, and to be very honest, this is something that I have been following in my practice, is what the authors refer to as the nocebo effect. Nocebo effect, in other words, is don't see, don't know. So I have noticed that you have a highly educated parent and you start telling him about what side effects to anticipate, and he invariably comes back and tells you that yes, my child has been vomiting. Best is this is what I follow. I don't know whether it's correct, ethical, or not. That keep it in mind. And in a way, it seems to work out that very young children who are maybe 2 and 3, who have not yet understood the story, you'll see that they seldom come back complaining about vomiting. Otherwise, they talk about antiemetics, changing the route, what we spoke about. But there's a fascinating study from India in adults which talks about the role of caffeine, which then could be translated to dark chocolate. And using dark chocolate to mask the taste could also perhaps help us to remember Mary Poppins saying just a spoonful of sugar makes the medicine go down.
This is a very nice solution for Swiss people, chocolate. But you know that in dark chocolate you have caffeine. And that may be also the reason why caffeine seems to work also against methotrexate intolerance. But
Truly,
another point, what we try to use, and I had already one or two success with this, is to use hypnosis. With this technique, maybe you can reverse this nocebo effect and reverse this psychological, if I can call it psychological, but psycho body effect. I don't know if you have experience with this or experience with other possibility to cut this emetic problem.
no, I've had one or two cruel parents coming and telling me that they inject their child in the middle of the night when the child is fast asleep, and they've got success with that. But I would find it rather difficult to advise that to a parent. But on a lighter note to end this, Michael, imagine that the parent did not sleep the night because the child was vomiting, and now you've given him caffeine at 8 in the night, and he's bouncing around the walls. He can't sleep because of dark chocolate. Until next time, Michael, till we raise another issue. Lovely to meet you again.
It was really great. So I hope you will have a very nice weekend, maybe with a lot of Swiss chocolate. And I see you then on next Friday. Okay. Bye bye, Raju. Bye bye.
Bye.